One of the drugs that's been looked at in colon cancer is a STAT3 is a stem cell inhibitor. So napabucicin is a stem cell inhibitor that blocks STAT3 pathway. So STAT3 pathway, activation of STAT3 pathway can actually cause many issues. It can cause can cause oncogenesis, can increase angiogenesis, and it can actually upregulate PD-L1, thus allowing tumor cells to evade immune mechanism. Therefore, based on the rationale, the napabucicin was studied in colon cancer in a phase 3 study. This was a randomized phase 3 study in a patient who were refractory, got randomized to napabucicin versus blood placebo. And the primary endpoint was overall survival, and unfortunately, the study was negative. However, they collected tissue and they were trying to look at any biomarker for the study. And they looked at what a phospholstat biomarker. When about a quarter of the patient was positive, staying positive for this p-stat area. And in those patients, there was an improvement over survival by about 2 months, 5 months versus 3 months, telling that this p-stat, the biomarker, may become a potential biomarker for stem cell inhibitor. However, once again, this is a post-hoc analysis. So once again, it's not ready for prime time by no means, but it is something of use. Now, based on some of this data, currently at this time, there's a randomized phase 3 study going on right now using combination of FOLFIRI plus napabucicin versus FOLFIRI alone in second-line setting. Now, they're not enriching patients who are positive for p-stat. However, they're collecting tissue in this study to look back at retrospectively to see if this is a good biomarker for the stem cell inhibitor. So we're eager to wait for the result of that study, and hopefully once that result, we'll find out if this p-stat is a good biomarker for stem cell inhibitor. So other area of interest that's been going on right now is that with immunotherapy, we know that it's only 5% of patients that are candidates for a checkpoint inhibitor. So the biggest research ongoing right now is trying to see if we could convert what we call a cold tumor to a hot tumor. So last year in ASCO in summer, there was a nice presentation by the group in Japan where they combined a TKI, regorafenib, plus a checkpoint inhibitor, nivolumab. Now, the whole concept of that behind is that we know that microsatellite stable, generally speaking, the checkpoint inhibitors do not work. But by giving regorafenib at the beginning with the combination, you're able to change the microenvironment, allowing the checkpoint inhibitor to work better. And the results was somewhat fascinating that the response rate is close to 30% in microsatellite stable patients, which is pretty obviously very high because we know that as a single agent regorafenib, response rate is less than 5%, and a single agent checkpoint inhibitor response rate is close to 0. So that combination is something that has got a lot of attention to it. Therefore, obviously we need more data on it. And at this time, even at our institution, we do have a phase 1 / phase 1b study going on right now. Very similar study to the Japanese group with a combination. Only caveat is that because of toxicity of the regorafenib, in the group in Japan, they use a low dose. They recommend 80 milligrams of regorafenib versus full dose of plus a full dose of nivolumab, because of the rash and fatigue issue. So I think that's the way we're going right now. So obviously we have to wait for the more results. I'm hoping that same results could be duplicated here in the U.S., therefore possibly offering this option, a combination option to patients that's diagnosed with MSS colon cancer.
There's a number of novel areas coming in research. I think in the highest on a lot of people's radar is trying to understand the potential of regorafenib and nivolumab to provide benefit for a microsatellite stable refractory colorectal cancer, kind of a provocative Japanese study that reported a high response rate above 30% in an MSS colorectal cancer population. And there's confirmatory studies ongoing in that space. I think in general, there's interest in trying to figure out how do we combine targeted and IO treatments. For example, the BRAF setting, there's a study of encorafenib, cetuximab, that's BRAF and EGFR inhibition, combined with PD-1, nivolumab, inhibition in microsatellite stable BRAF mutated colorectal cancer. And so the idea is that can provide augmented benefit and hopefully longer duration of disease control than single agents alone. We're also very interested in the area of the antibody drug conjugates, which are now starting to show some activity in colorectal cancer in HER2 and potentially HER3 expressing patients. And so this is another area of interest. IO combinations more broadly is an area of continued interest. We recognize that in metastatic colorectal cancer, there are a subgroup of patients that are what we call an immune desert. There's really no engagement with the immune system. And really thinking about how do you use vaccine or T cells or bispecific strategies to really recruit an immune response. But there's others that are really more of an immune excluded phenotype, that there's something in the microenvironment, MDSCs, for example, or TGF-beta signaling that may be playing a key role in really suppressing the immune system. And combination strategies to target those different populations with checkpoint inhibition are ongoing to really try to understand, is there a subgroup of patients where a checkpoint or IO combinations may be beneficial even in the setting of a microsatellite stable tumor.